This is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight a paper of particular interest to the readership by interviewing one of the, in this case, two of the authors of an article from the July 2022 edition of the journal. The article I picked for more in-depth exposures entitled Demographic, Lifestyle, and Serologic Risk Factors for Rheumatoid Arthritis, RA, Associated Bronchiectasis, Role of RA-Related Autoantibodies, and it is by McDermott and colleagues. And today I'm pleased to be speaking with Dr. Gregory McDermott, who's the lead author of the paper, and Dr. Jeffrey Sparks, who's senior author, who will discuss with me the risk factors for bronchiectasis in patients with rheumatoid arthritis. Jeff, Greg, I want to thank you for taking the time to speak with me and to the audience. And so let us begin. So first question is an easy one. What led you to perform the study, and how does it differ from previous studies in bronchiectasis in patients with RA?
Well, thanks so much for having us, Dr. Silverman. We're really glad to be here to share some of our work about RA bronchiectasis. I guess to take a step back. So I'm a second-year rheumatology fellow at Brigham and Women's Hospital, and I have always been interested in multi-system rheumatic diseases and understanding how and why autoimmune diseases can target multiple organs in addition to just the joints. So since the beginning of fellowship, I've been really fortunate to work with Dr. Sparks, looking at rheumatoid arthritis-associated lung diseases, and we've worked together on a couple projects related to rheumatoid arthritis-associated interstitial lung disease. And in the course of that work, realized that I think that there's a pretty significant need to better understand bronchiectasis in rheumatoid arthritis. Taking a step back, I just wanted to talk for 1 second about bronchiectasis in general, with the big caveat that I'm a rheumatology fellow and not a pulmonologist. But my understanding is that bronchiectasis occurs when there is dilation and distortion of the airways of the lungs. And this can lead to cough and mucus production, shortness of breath, dysbiosis of the airways, and recurrent infections. And we've known for decades, really, that there is an association between rheumatoid arthritis and bronchiectasis. But research into this condition has actually been quite limited for a couple reasons. First of all, there's significant heterogeneity in the way that bronchiectasis has been researched and also how it can present. It can be clinically apparent, and some studies have investigated that, where patients have both symptoms of bronchiectasis as well as characteristic findings on radiology. But it can also be subclinical, and some studies have looked at the prevalence of bronchiectasis in screening studies where CTs were done for research purposes. Another complication of research into bronchiectasis is the fact that it may occur in conjunction with other lung diseases. So obviously there are many overlapping symptoms. I described shortness of breath, cough, sputum production. That can be seen in chronic bronchitis and COPD. And it can also overlap with interstitial lung disease, where the lung disease itself, especially scarring or inflammation, fibrosis of the lung parenchyma, can really pull the airways apart and cause what's called traction bronchiectasis. And this is another mechanism where it can occur. But it can also occur on its own. And this is the phenomenon that we termed isolated rheumatoid arthritis bronchiectasis. And in this study, we really wanted to focus on that entity, these isolated bronchiectasis cases, where it's occurring in the absence of underlying interstitial lung disease, not traction bronchiectasis, and try to determine what are some of the risk factors for developing that condition in particular. As far as we know, I believe we are the first study to really focus on that isolated bronchiectasis group in particular. And we wanted to investigate some of the risk factors for developing that condition. We focused specifically on rheumatoid arthritis-associated autoantibodies. And we also wanted to investigate body mass index and how that contributed, because that's a known RA. Having a high body mass index is a known risk factor for having interstitial lung disease in RA. So I think those were some of the things that we really wanted to highlight about this work. Jeff, anything you wanted to add?
No, I think you covered it very well. I mean, obviously, there's been a huge surge in interest in RA-ILD, and we're certainly very interested in that as well, but this is sort of a relatively common, relatively neglected facet for one of our most common systemic rheumatic diseases. And we took advantage of our lung phenotyping program to really find patients who had isolated bronchiectasis that we know is not a consequence of RA-ILD, because I think that's been something that's muddied the literature up prior before, because traction bronchiectasis as a consequence to ILD is probably pretty different than someone who develops it in isolation.
Thank you. That makes perfect sense to me. And thank you for the excellent introduction of bronchiectasis to another non-respirologist. And I think you've really pretty well went over the aims of your study. Is there anything else you want to add that we may have missed?
I mean, I think I just wanted to highlight that we really wanted to look specifically at the impact of some known ILD risk factors on RA-associated bronchiectasis to see if we could really compare and contrast between the two conditions. So we looked at kind of age, RA duration, autoantibodies, cigarette smoking, body mass index, which I mentioned is a higher body mass index is a known risk factor for RA-ILD. And we wanted to see, are these risk factors the same in both conditions, or are there some differences that we can discern between them?
Anything to add, Jeff?
I don't think so.
Okay, no, that really explains your choice of risk factors to examine rather than what some people, I hate to say it, I know you didn't do it, I'll look at 20 risk factors, but pretend I only looked at 5. So I think that really puts it in perspective.
Right.
And what exactly did you do? How did you perform the study and over what time period? Because it's quite a large cohort.
Yeah, so the design of the study was a case control study. And as the source of both cases and controls, we used a cohort of RA patients who have been identified within the Mass General Brigham Biobank, which is a large institutional biobank within our healthcare system. The biobank started recruiting patients, I think, around 2010, although their records, once they enroll, may predate that date. And we examined their records all the way through, I believe, September of 2021, which is, we're updating it now, but that was, I think, the cutoff for this particular study. And Dr. Sparks and his team have identified over 2,000 RA patients in that biobank. And we started by identifying all of the patients in that cohort who had a clinically performed CT scan of the chest. We then manually reviewed the chart of all those patients to look for clinical evidence of bronchiectasis, RA-ILD, other lung diseases, and also performed a research radiology review where we took the CAT scan of the chest that was performed closest to biobank enrollment and had performed a research radiology review by a sequential reader method, where we have 3 of our radiology colleagues, so two of them would read it in a blinded fashion, so they don't know the clinical context, they don't know the prior clinical read on the scan, and they score it for presence and severity of interstitial lung abnormalities, bronchiectasis, other lung diseases. If the first 2 radiologists agree completely, we're done. If there's a disagreement, there's a third radiologist who comes in to basically break the tie. And so using those screening methods, we selected cases, and the cases were patients who had clinical and radiologic evidence of bronchiectasis, but no evidence of concurrent interstitial lung abnormalities on that CAT scan. And so those were the isolated RA bronchiectasis cases. And the controls were RA patients who had a CAT scan, but had no clinical or radiologic evidence of bronchiectasis or interstitial lung abnormalities or any other interstitial lung disease. We compared the cases and controls using univariate comparisons, and then a multivariable logistic regression adjusted for the other factors to see what were the most important risk factors associated with bronchiectasis.
Yeah, I would only add that the biobank also surveys every patient who enrolls. So I think in particular, the thing that comes to mind is smoking, airways and lung damage.
Of course.
So we really wanted to investigate smoking, but also we really wanted to adjust potential other risk factors for smoking. So we had, really granular detail about status and pack years. The other thing is we're able to link this to the medical record. So we're able to extract, the serostatus and titer of rheumatoid factor and ACPA on all the patients, which obviously is another, keen interest of ours. So it was really a, fantastic data set and a really good project for Greg to spearhead to, this is really a program to phenotype RA patients very finely from a lung perspective. So we think it's going to have a lot of future directions too.
That's a fantastic data set. Mm-hmm. Just as a ballpark, I know you're not prepared for this. What percentage of patients seen over this time period is your guess, just that enter into your biobank? Are we talking 90, 80? Do you know approximately? Any feel for this?
So I think there is a larger RA cohort within the entire electronic health record, so not of which the biobank is a subset. And I believe there's about 16,000 RA patients in that cohort. So 2,000 compared to 16,000. So, 1 in 8 patients may enroll. Jeff, I don't know if you have a different.
Well, some of them were seen prior to the biobank starting.
That's true. That's a good point. Yeah.
And presumably,
we'll have to look
no
into
selection. Sorry, I was going to say, presumably there's no selection bias.
Yeah, that's a nice thing about the biobank is they really were recruiting, piecemeal. This was not an RA recruitment study, so we hope it's somewhat generalizable. But certainly, people who are interested in research are going to be more amenable to sign up
and get you better data.
Yeah.
Excellent.
Yeah, the overall size of the biobank, I think, Jeff, was about 130,000 people now.
Yeah.
So, not too far from the general population prevalence of RA, if you think about it like that.
That's fantastic. Okay, and what were the major findings? If you want to review those.
Yeah, so overall, we identified 57 case patients with isolated RA bronchiectasis, as well as 360 controls who did not have any RA-related lung disease. We found that the patients with RA bronchiectasis was associated with having being older, was strongly associated with RA-related autoantibodies, and in particular having seropositive RA, so a positive rheumatoid factor and or anti-CCP antibody, or the positive rheumatoid factor in isolation had about a 4-fold increased odds of having isolated RA bronchiectasis. We also found that having a lower BMI at RA diagnosis was a risk factor for developing RA-associated bronchiectasis. And I guess I'll mention this. So we did see a statistically significant difference in abatacept use between groups, with a little bit less abatacept use in the bronchiectasis group. However, I really want to caveat this was very, very limited by a very small sample size, and our study was not done in a claims database, but is something that we, I guess, technically saw in our results. I think that those findings identified several potentially novel risk factors for bronchiectasis in RA. As far as we know, I think this is the first study to demonstrate an association between RA autoantibodies and bronchiectasis. There had been one previous study that showed a trend towards an association that didn't reach significance. And interestingly, I think the strength of that association may be stronger than what we see in interstitial lung disease, or at least the association between autoantibodies and interstitial lung disease has not been universally observed. And I think our finding related to BMI is also something that we think is really quite interesting. As I mentioned, a higher BMI is a risk factor for RA-ILD, and we saw the opposite in bronchiectasis, where lower BMI at RA diagnosis was a risk factor for bronchiectasis. And similarly, we did not observe an association between smoking and bronchiectasis, whereas smoking is really a very strong clinical risk factor for ILD. And I think these contrasts in the risk factor profile just highlight that they are may really indeed be separate conditions.
That's fascinating, and it really does justify your selection of population to eliminate ILD. because as you went before that, there's this traction, bronchiectasis, that would confound findings. So I think does certainly make it novel. And I think it really asks so that you really did go over how you contrast. So anyone you want to add of how your study compares and contrasts to the literature?
Well, there's not a lot of literature on risk factors for ILD. We actually had previously done a systematic review and meta-analysis and found just a handful of papers, and a lot of them had some of the issues that we already talked about. Sorry, my light just went out.
That's okay. But now it's shining on you.
There we go.
So can I just clarify something for my simple brain when we're talking about autoantibodies, or actually being a lupologist? We're really talking about rheumatoid factor and CCP, is that correct?
Correct, yeah.
Okay.
Yeah, we didn't investigate any of the more other autoantibodies that are more for research purposes. I think an interesting, important future direction, but not part of this study in particular.
No, it doesn't in the least bit take away from your findings. It's just more that ANA or anything else that may.
Oh, right. Yeah, no, we didn't investigate any of the other clinical autoantibodies as well, just the rheumatoid arthritis associated ones.
Sure. Good future direction.
So in the discussion, to me, it was fascinating, your hypothesis of the pathogenic link between airway inflammation and RA. Would you like to expand upon this for the reasoning that you had this hypothesis and the implications?
Yeah, so in the discussion, we did comment on a possible pathogenic link between airway inflammation, airway disease, and development of kind of articular rheumatoid arthritis. And this was a reference to the so-called mucosal origins hypothesis. And Jeff, feel free to jump in and if I'm misspeaking at any point, but this hypothesis basically holds that there are certain mucosal sites in the body that play an important role in the development of autoimmunity and rheumatoid arthritis in particular. Some of those sites, those mucosal sites, are the lung, the gingiva around the teeth, the gut, cervicovaginal site. And in those sites in particular, there's this complex interplay between foreign antigens, bacteria, as well as our local immune system. And when that system is working well, our mucosal immunity protects us from infection, but also rapidly and efficiently clears away local antigens without triggering systemic autoimmunity. However, in the setting of other conditions, such as damage to the mucosa, perhaps through infection or smoking, other respiratory inhalants, dysbiosis, perhaps mucosal overproduction, the delicate balance there can become dysregulated. And that allows for the presentation of those local antigens more systemically and the development of a more systemic immune response. And the idea is that these mucosal sites in particular are areas where these antigens and local antibodies are interacting, and there can be molecular mimicry to environmental antigens that then trigger the development of possibly pathogenic autoantibodies. In particular, those antibodies may be citrulline antibodies or the anti-citrulline protein antibodies, or ACPA, which rheumatologists are obviously familiar with in the form of anti-CCP. There's been some really interesting research showing increased levels of circulating serum ACPAs in patients with bronchiectasis in general who don't have RA, as well as I think several studies demonstrating increased levels of IgA ACPA in the sputum of patients pre-development of articular RA. We were not specifically investigating this mechanism, but I think that our study showing an association between RA-related autoantibodies, a strong association between RA-related autoantibodies and bronchiectasis, as well as just the overall association between bronchiectasis and RA, just further highlights the importance as the lung as a potential site of autoantibody production or RA pathogenesis. I think a lot of additional work is needed in this area to understand these mechanisms, and I think really understand the timing as well. There's a big chicken and egg question related to this. Does the lung disease precede the development of RA, or is there preclinical lung disease related to rheumatoid arthritis? Kind of how do these interact with each other, I think is not completely known. But we thought that our findings, I think, just add to this potential understanding of these mechanisms in this hypothesis.
Anything you want to add, Jeff?
Well, I think he covered it really well. Obviously, this is a bit of speculation, but it's a really striking finding, the strength of association with these antibodies with bronchiectasis, and it's really stronger than any other lung manifestation that we've investigated. And also a bit interesting that the rheumatoid factors seem to be slightly stronger than ACPA. So, that's an antibody that's been around a long time, and I think that's another, it adds information beyond just ACPA. I think the only other thing to add is that, our group's been very interested in the lung as an initiating site and as a site of clinical outcomes. And it's kind of really interesting to see how common diseases such as asthma and COPD might have a bidirectional relationship with rheumatoid arthritis. And then the more specific sort of extra-articular manifestations of RA, bronchiectasis and ILD. So really, I think it's a really fascinating area to understand how the lung might be an initiating site and a site of outcomes. And we've been terming that the respiratory burden of RA. And I think this is something that's sort of the tip of the iceberg. Bronchiectasis is something that a lot of patients have under the surface, might be contributing to outcomes. And so we really want to understand how this affects quality of life, treatment response, recurrent infections, and certainly mortality. So I think this really opens up many avenues. And of course, this is a biobank, so we're going to delve into genetics and biomarkers as a future direction. So stay tuned for more.
Great. Anything you want to add that maybe we missed? Greg?
I think that pretty much covered it from what I wanted to share. Jeff, was there anything else? I think
it's a fascinating paper. I think the BMI is its own discussion probably, but it's really the opposite association, where actually lower BMI was associated with higher risk of bronchiectasis. So this kind of, the thinking about rheumatoid cachexia, people who are underweight. We also delved into whether maybe there were, cystic fibrosis carriers. No one really had cystic fibrosis in this population, but thinking about, malnutrition, undernutrition, and dysbiosis that might go with being underweight as sort of another novel research avenue, because I think most of the research is focused on obesity.
Yeah, I was fascinated by that. And as you said, the cachexia, maybe the chronic inflammation we know that's associated with cachexia, all those things. I thought it was fascinating, and thank you. And I too think this is a fascinating play, although I'm not an RA person and certainly not a respirologist, but you got me interested in this. So anyway, I really want to thank you for taking the time, giving myself certainly new insights into RA and bronchiectasis in the lung. And as a pediatric rheumatologist, you've converted me. There is something here. Maybe studying RA isn't so bad. So anyway,
you're converting us too.
It was fascinating. And as I said, I'm sure the audience learned a lot. I learned a lot. And I really suggest to readers and listeners that you do read the full-length article, because although it was an excellent discussion, there is actually even more in the paper entitled Demographic, Lifestyle, and Serologic Risk Factors for Rheumatoid Arthritis, RA-Associated Bronchiectasis, the Role of RA-Related Autoantibodies. It's now available at the journal's website at jroom.org. And if you have any comments, either about this interview or the paper, please go to Twitter at jroom or by email at manuscripts@jroom.com. And I want to thank everybody for joining us, and hope you'll come next month when I've selected an article for the August 2022 edition. And I really do want to thank Greg and Jeff for an excellent article, for submitting it to the journal, and for a great discussion. Thank you.
Thanks so much for having us.